everyone. Can you hear me? Okay. I'm Dr. Dattoli, and welcome to the Prostate Cafe. This is our monthly meeting where I'm here to answer any and all questions that I can to the best of my ability. I'd first like to thank the Dendron people who are here for a product called Provenge, who will be providing your breakfast. It's just running late. Told it's been 6 minutes, so we'll let you go when that time comes and grab some breakfast. But anyhow, they're a very interesting company. They use a product which is actually an immunotherapy, which interestingly is not a chemotherapy and it's not a androgen therapy that we use, both of which can be used for prostate cancer, especially androgen therapy. And we do that here. And the way it's done is you go to a specific place where they remove your blood. It's called leukapheresis, and they extract critical immune cells. And then it gets sent to a specialty lab where they design immune agents, or they actually codify your cells to be reinfused into your body here, and those cells then go and supercharge your immune system to attack the cancer. So it's very interesting. And it's called Provenge. But that's it, and they're sponsoring breakfast, so that's why I bring them up. Anyhow, are there any questions that you have to start out with? If not, as you know, I can do a lot of talking.
Well, I'll start with one.
Okay.
I've had an MRI, 3T MRI, and they didn't see any cancer. They rated it as a 2, unlikely. Is a 3T MRI the best tool to identify cancer absent a biopsy?
So the gentleman's asking about the utility of MRIs for imaging prostate cancer. I got to tell you that 10 years ago, the radiologist couldn't tell us a whole lot. They might be able to say on an MRI, well, I think there's a cancer. And then what they started doing is they started increasing the strength of their magnets. The reason they have to do that is that the prostate moves a lot, and the whole pelvic area actually moves a lot. And one of the reasons why we do a specific type of radiation called DART, because we have to move with you, and that's unique. But the prostate does move, and so they started to find, as they increase the strength of that magnet, they were able to get better static images. And they've gone up to 3T, which is right now considered the gold standard with MRI imaging, and I'll only refer to a center that has the 3T magnet. And then based on that, the increased strength of their magnet, they're able to be a little more definitive and say, yeah, I think you have a cancer, or you do have a cancer. And then what happened is they started using something called multi-parametric imaging, and what that did is it brought yet a whole nother level of accuracy to their readings by incorporating a combination of static images. So this is a side view of your prostate and the tissues around it. This is a front view, but it also enlisted functional MRI imaging. So for those of you who've had it, as you probably have, you get an you haven't had
an MRI.
Yeah, you've had an MRI. You get an injection, and then that's looked at with the contrast enhancement. And so there are different ways of looking at it. One is called APC, one part of the multiparametric way of looking at it. 2 is DWI, diffusion weighted imaging, and then finally contrast imaging. And with those 3, they've gotten really good, so that now they not only tell us, the oncologists and urologists, that you have a cancer, but they also say, and we predict it's going to be this aggressive. So they use a scoring system in their world called PIRADS. And PIRADS goes from 1 to 5, 5 being their prediction that it's going to be the most aggressive cancer, 1 being their prediction that it's going to be the least aggressive cancer. So this gentleman just told me that he had a PIRADS 3.
2.
Oh, 2. Okay, so you're in a low risk. So, that may be worthy of just repeating and following, unless the PSA has gotten to a certain number.
I guess my focus was more on whether, for example, think you use a color Doppler. Is that an ultrasound?
Yeah.
Is that more effective? And what's the best tool to look into the body and see cancer if there is such a thing?
So he's asking other imaging. Let me talk about imaging then, okay? And I'll kind of cover all the bases. So there are different tools that are used to image prostate. One is an ultrasound. Classically, an ultrasound uses grayscale imaging. It looks for deeper hues of gray, even black, because tumors create, they're hyperdense. They make more cells. So there's more cells in their little matrix that forms a nodule that we see on the scan, a stone, a marble, and that could be cancerous. The CT scans tell us something about the edges of the prostate. So we do light speed helical scans. So we do fine section images to try to figure that out. But we also look for lymph nodes, which are these organs in our bodies that are commonly affected by prostate cancer. And then third is the MRI, which I just told you its values, and they've gotten really good at that. We like to have MRIs done, multiparametric MRIs, and we see it as a complement to our scans, okay? And we do something specially here called three-dimensional color flow power Doppler ultrasound. Now, its utility takes it to another level because we can look at those dark spots that might be on regular grayscale ultrasound, but we also know that cancers require a lot of blood flow going to them. And so we specifically look at vascular patterns associated with the cancer. The fact is, from that perspective, I would say it's better than an MRI, which does look at some vascularity, but not as good as a 3D color Doppler ultrasound. Also, the 3D Doppler ultrasound is interactive. So for example, when we do biopsies here, we do transperineal biopsies, and I like, as I said, to have both. But we can fuse an MRI with our ultrasound units. As soon as a person moves, all bets are off. You lose all your coordinates. And that's an inherent flaw with MRI imaging to do biopsies. And there are a few centers in America that actually have MRI machines that you're under getting a biopsy done interactively.
With an MRI?
With an MRI, yeah, but it takes forever. And so, it's just not the right way to be doing prostate biopsies, although, as I said, there's a couple places in the country that do MRI-guided biopsies, but it's a long, laborious process. So what I like to do is we'll use the MRI information and then use our three-dimensional color Doppler ultrasound, because if you move, we're going to move with you. It's completely interactive. And, and that's just the bottom line. We could also see more about the edge of the gland. I'm trying to educate urologists and oncologists, and especially radiologists, to the fact that the prostate does not have a capsule. And that's a real fact. You could Google it. It really, really doesn't. But they still go back into the old literature and they talk about a capsule associated with the prostate. There isn't one. And
can you explain what a capsule is?
Oh, yeah. So most organs in our bodies, he's asking, will have a thick rind around it. And as you know, when we talk about prostate, we often make analogies of small fruits or a walnut. But all those things have rinds, or they have casings like the walnut. Okay. And because of this, and sometimes that casing is pretty large. Most organs in our urinary systems have capsules. Okay, the bladder has a really thick wall to try to get through. The kidneys have a giant capsule. But what it means is that for cancer, which might be right here, to penetrate, it runs into a wall. And then it has to make it through the wall. And to get to the outside, it takes a while. So when we talk about cancers in general, we often talk about a cancer having to break through the wall or its capsule. Okay, well, the prostate doesn't have a capsule. And that makes it unique because I say in the urinary system, even the genitalia, penis, the testicles, they have capsules. And the prostate doesn't. And So the prostate, let's see, this is not working. The prostate is shaped something like this, somewhat in contrast to the fruit or the walnut. It's actually more like a heart, with the bottom being smaller. We call the bottom the apex. We call it the top the base, which is also upside down. Apex usually the top for you skiers, or just knowledge of that. But and then of course it has a right and left side to it. But a couple features about the prostate which makes it unique is that the tumors typically begin right on the edge. We call that the peripheral zone. They don't commonly begin in the central or transitional zones. Most of them are always in the peripheral zone, and when you see biopsies, you'll see on the report biopsy from peripheral zone, apex, mid-gland, base. Well, what happens is cancers, they microscopically send feelers out. All cancers do. That's what they do. If this was a cancer, for example, here, and it sends out its feelers because it broke through the capsule, when you try to remove the cancer, you know that. And you can't see these microscopic cells. So when you do remove a cancer, you go out of your way not to just remove this, which might be the lump, the bump, the nodule, the hard spot, or the stone seen on an MRI or a CAT scan or an ultrasound. You go wide in an attempt to get it out. That's how you do cancer operations. In this situation here, what makes it difficult is that the prostate has no capsule, so it has a fairly easy time getting into the tissues around it. And that's an important aspect of prostate cancer because these are microscopic. You cannot see them. However, in contrast to this picture here, where you took a wide swath around the tumor to make sure that you got an area that was not cancerous, you can't do that with the prostate because it's surrounded by too many critical structures. So it has, these are actually seminal vesicles, which are the reservoirs for the fluid, and then the bladder, which sits above it. But on the side of it, it has these big nerves, arteries, and veins that run around it. We call those neurovascular bundles. Down here, there's another structure called the urogenital diaphragm. But anyhow, it's busy. And so when you remove the prostate surgically, you can't, if you know there's a tumor, let's just say, like on this right here, I'm showing you the left mid-gland. But if you know there's a tumor there, you might go a little wider. There's only so wide you can go because you get into some critical structures that you just don't want to be getting into. And so when prostate surgery is done, the way it's removed is just you basically sculpt it out. You excise it like this, and just peel it off of those areas. And so you can understand why if you do that, you're leaving some cells behind. MRIs don't show a lot of this because they can't pick up on microscopic disease. They only pick up on macroscopic disease. And I see so many studies, MRI studies from around the fruited plain saying the capsule is bulging, it's overlying the capsule, it's abutting the capsule. No, it's probably leaking through the capsule because there is no capsule. There's nothing to hold it in. Now that works very conveniently for the urologist. In fact, all the studies having to do with prostate cancer works conveniently for the urologist because he can tell you, oh, you had that MRI done and it's confined. It's locally confined. You can read it yourself. It says it didn't go through the capsule. It only bulged the capsule. It only was opposed to the capsule. It was, abutting the cap, but it didn't go through, so we can remove it. Okay, without your knowledge that it's probably got some tentacles leaking out, cancer cells leaking out. That's a problem. So just so you know, there are limitations to using MRIs in prostate cancer. And from my perspective, they've gotten really good at predicting if there's a cancer and how aggressive the cancer is going to be. But they haven't gotten as far as knowing the capsule. And I'm just really, because on my list, I try to call a radiologist a day to tell them, you review my scans and, I don't appreciate you using a capsule. And you should know that's old nomenclature. We just don't use it anymore. And they agree because they can't disagree because there is no capsule. But anyhow, still the literature is filled with capsules. So that's one of the shortcomings of multi-parametric MRIs, which again, I credit the radiologists. They've gotten really good in doing that, and they're rarely wrong. So in your case with a PIRADS 2, it could be a low grade, it could be a benign adenoma, and we just don't know. There are some studies that could be to your advantage. It's just a urine study called a 4K score.
I'm having that done.
Yeah, it's probably the best of the predictive tests, but it's not great. I mean, it's not 100%. I'm not sold on a lot of other of the forecasters like Decipher and Polaris, but of all the ones that I have used, the 4K score is the most advantageous. It has the most information associated with it.
So I understand that surgically hard to get all these little stragglers or feelers. So when you're using, for example, radiation, external beam, you are able to access those little microscopic areas, I think.
Yeah, so he's asking, what do we do with radiation? Well, yes, absolutely. We're able to access this microscopic element outside the prostate and be very careful about that and avoid the bladder and the rectum. And so the rectum sits behind the prostate. This bladder sits on top of the prostate. The urogenital diaphragm, important aspect of this. So the prostate urethra goes right down the center, okay? And that's the pipe that gains access from your bladder to the outside world. Right here is a really, really big muscular sphincter, and the urine is controlled by that sphincter. I call it the control center of your urine in men. And, the studies have identified, that most control does come from the internal sphincter of the bladder. And when it releases the urine, it's because you're opening up your sphincter. You're saying, go, I want to release my urine, and it goes, and then kind of comes down this way. It exits. There is another group of sphincters right here, and they're part of this urogenital diaphragm. And they don't do that much. Studies have shown maybe 5%, maybe upwards of 10% of the control comes from this one. But one of the things and one of the important aspects of prostate cancer is that when you do remove it surgically, you have to remove those internal sphincters. No one's done it differently. And, I know also patients are not told so much about that, but it's a big deal because now, you've been controlling your urine for your lifetime here. Now you have to give all the control to these tiny little sphincters below the prostate. And that's a problem, just because it's typically not up for the task. And, the way prostate cancer is, it doesn't affect 20-year-olds. It affects older people, 40 to 90, and they're losing muscle mass each and every year. And so muscle mass is also being lost from the external sphincter, and so it's just a matter of time. So if you're not completely incontinent of urine after the surgery, because water finds its way, and urine is just water, and it heads down, and as time goes on, it becomes a bigger problem. So that's an issue. Of course, the prostate is a sexual organ, and again, you can review this. It's a G-spot in men. It carries most of the nerves that come out and join these bundles and then go to the penis. It has everything to do with the creation of the ejaculate, which it's stored in the seminal vesicle organs, and then it has a lot to do with the orgasm. So you appreciate, if your prostate's removed, how all those functions are going to go bye-bye.
Just as a general crude statistic of the hundreds, maybe thousands of people that you treated with some form of prostate cancer, do half of them end up with incontinence or
Oh, no, we don't. So with radiation, we leave the internal sphincter alone, and we leave the external sphincter alone. So there should be no incontinence. Now, there are some men who've had some exculpation of their urethra and the internal sphincter by other procedures, such as, we call them TURPs. There are vaporizations. There's all kinds of other procedures which could, kind of violate the internal sphincter and could compromise its its function. But and then again, we're worried about this, but we don't touch this one, and we try to leave whatever's left with your internal sphincter maximally behind, so that we typically don't have that as part of our vocabulary. Can it happen? Yeah, anything can happen. But generally speaking, incontinence, leakage is not a big
Same with
issue.
erectile dysfunction.
Same with erectile dysfunction. So most men, again, we leave these neurovascular bundles alone.
Are they really clearly located? Like, can you see them? These
Yeah, you can.
bundles?
Yeah, they run right and left in a kind of a on the clock of the prostate, and so we know where they live.
Can you miss them with the beams then?
We can miss them, but here's the thing: the neurovascular bundles can take an enormous dose, so they can take a really high dose. Especially nerves and vessels can take big giant doses of
The dose
radiation.
that would kill the cancer.
But what we typically do is we treat a dose that would sterilize cancer cells, but not enough to knock out the neurovascular bundle. But again, nerves can take a really high dose. I used to do a lot of brachytherapy, which is where you put these small pellets into body parts. And when I was at I can't do them here because we're limited, but when I was at these big hospitals, I used to implant tongues and lungs and brains and breasts and all these areas where tumors sit right on nerves and vessels. And for example, women with breast cancer, they would have lymph nodes beneath the axillary region in their armpits. And that's where some big nerves like the brachial plexus lives. And I used to do implants right in there, like put them right in there. They would never lose their neurologic function, sensory or.
Maybe a little bit too mechanical, but for example, when you're doing a needle biopsy, you're punching a lot of holes, trying to take samples. And obviously, is it always easy to avoid these nerve bundles because you know where they are and you just don't go through that area?
With the way I do it, yes. And the way I do it, definitely, because again, I can track vascular patterns. So I immediately see these big vessels running astride the prostate, and I stay away from them.
What about the urethra itself? It's a cylindrical object, crudely, and there's a tube running through it, and you're coming more or less from the front, I guess, or no, from the back, from the perineal area. So you've got one sort of axis area in general, I think. Now you're trying to get through to all quadrants of a three-dimensional object with a tube running through it, right? Mm-hmm. Which is kind of a trick, isn't it? It doesn't go around corners, this needle, mm-hmm. right? So nevertheless, you're able to get a good enough sample to still avoiding the tube and the nerves and everything else.
So he's asking if I can avoid the urethra, and the answer is absolutely yes. So the urethra you could see when I'm doing my Doppler ultrasound, I can see it. Okay, it's pretty clear where it lives. Now, what we also do is we really trace it out because during the procedure, after you're asleep, we put a Foley catheter in, okay? And we remove that same catheter before you wake, okay? So you never know it. But we do put it in there, again, for some additional visualization of the prostate urethra to avoid it. I go out of my way to avoid it because you just don't want to pierce that, because that, as it is, the prostate gets affected, obviously, by the biopsy. It shares that with the bladder, and the bladder likes to have this really nice rhythm, to allow urine to flow easily. But you can understand when you're doing prostate biopsies, the prostate's getting inflamed. It shares that with the urethra, with the bladder. And for a little while, the bladder is a little dysrhythmic. It doesn't have a good rhythm to it, and it takes some time for it to calm down and then just allow the normal flow to happen again. So, but there are, I guess this would be a time to discuss the different types of biopsies. So, classically, almost universally, prostate biopsies are done through the rectum. Okay, and that's the way urologists have been trained. And since most urologists, do the biopsies, that's the way they do it. And it's through the rectum. And let me get another diagram over here. I may come back to this one. But what happens is, so again, from a front, well, let me draw this from the side. So if the prostate is here, and again, the bottom of it is smaller, okay? The rectum runs right behind it, like this. There's an area right here, But this area right here is called the anal rectum. That's the exit of your rectum, your feces. And then these appendages here, they sit like this between your rectum and the prostate. And then the urethra travels like this, and it's heading to the bladder, and the bladder sits above here. So you can understand that when you're doing transrectal ultrasound biopsies, you must pierce the rectum, and what happens is you put a probe in here, and the probe allows you to visualize the prostate. Now, if the cancers or their target areas around here, well, you can get to it. These needles are only so long, okay? But if you have a very large prostate gland, then there may be some cancers over here. That becomes challenging with the transrectal ultrasound method and may be missed. What you have to do is, and I used to do these with the rectum, but through the rectum, you have to compress everything to try to get so that that needle can actually reach here. And the needles are only so far. But you can understand with the urethra running right down the middle, then there is a more opportunity to hit the urethra as you try to come in, because it's somewhat blind, because most biopsies are done with the grayscale ultrasound. And you might be able to visualize the urethra, but it's not so great in visualizing the urethra. So one of the big problems could be location. You can't get to every location, and it could be a geographical miss, and you may be told that you don't have prostate cancer, but you do. It was just in a location where the transrectal ultrasound needles couldn't reach. The second problem is there's always bacteria in the rectum, and you'll be told to, prior to a transrectal biopsy, to do a flushing. You'll have told to do a fleet enema, you'll do a bowel prep, and all those things, but you can never make the rectum sterile. You just can't do it. So you're always going to be introducing bacteria from the rectum into the prostate. That's a big issue. And it's 100% of the time you're introducing bacteria. Now, do 100% of men get infections? No, they don't, because our bodies have immune systems and ward it off. Just like we're around COVID, you might not get it, but some men do, and for that reason, men who have transrectal biopsies, 15%, sometimes up to 18%, end up in a hospital within 36 to 48 hours with an infection. 5% end up in the ICU, which is a bigger infection because it became bloodborne. So that's a big deal. The third big deal has to do with this rectal wall harboring a lot of big nerves. So it's an area that's a completely sensory area. It's supposed to tell us when you got stool sitting there, and there's just big nerves there, and you just can't see them with a transrectal biopsy. So you're going to hit them. And, if you're not anesthetized, well, you'd be screaming, okay, with each snip. And some still do that. But even if you're anesthetized, then when you wake up, you're going to know it. It's in a smart.
Why did they start through the rectum? Was it because in theory you could get somewhat easier access to at least part of the prostate?
Yeah, because what he's asking, why did it start through the rectum? Why are they doing it that way? Really? Well, it's because back in time, the digital rectal examination was your gold standard for picking up prostate cancer. And back in time, what you would do is you would feel the prostate, and if there was a lump or bump palpable, you would actually, with your finger, guide a little needle and go in and biopsy the tumor. Yeah, I've done it that way too. But anyhow, the fact of the matter is that just got translated into, okay, well, if we're doing it that way, and that's how we're classically involving in biopsying prostate nodules, then we should also go through the rectum with a probe where we can actually see the whole prostate and biopsy it more accurately using that method.
Now you have a smaller area, an access area, so to speak, to the perineum. It's more localized in your entry point, which is not great from one perspective. So you're using longer needles to try to go everywhere you need to go.
Yeah, he's asking about that, but I'll get there. Okay, so again, big nerves get violated. That can cause a lot of pain, and that pain can throb for a couple weeks. Finally, there's a lot of vessels in the rectal wall, big vessels. And there are vessels also in the prostate, and there are also nerves in the prostate, but not big ones. like around the rectal wall. But the fact is that you engage these big vessels, and if there is cancer, and if you're pulling cancer out, and then it gets to this location right here, then you could be potentially circulating cancer cells. And the reason that is again, they're big vessels. Rectal vessels communicate more broadly, more widely, with your heart, your lung, your brain, your bones, everything in your body system. And that's why if you read about colorectal cancer, they commonly talk about, even sometimes just early to intermediate stage having to find liver spread or lung spread, and it's because there are big vessels down there. And so that's another aspect about transrectal that I don't like. So in contrast, there's a small area right here. It's called the perineum, and it sits between the scrotal sac and the penis, and it's a small area, and we can scrub that down. So infections are nil. I mean, again, someone can get an infection, things like that, but it's really, really low. Are you ready?
Does all this advances in imaging delay or replace the biopsies, need for biopsies?
I'll get there. Okay. So anyhow, what happens is through this area, which we can scrub, we still have an ultrasound probe, but here we use a three-dimensional color Doppler ultrasound, so we can see exactly where we're going. If there's a tumor here or here, there's no area we can't get to. And yes, the needles have to be longer than the ones here, but there's nothing that I can't get to in the prostate. And for no reason do I have to hit that urethra.
You don't.
No. Secondarily, we, as I said, we can scrub this. We can hit any location, so that lessens any chance for geographical miss. The vessels in the prostate are small, and you can still have bleeding. But what happens is the blood gets resorbed by the urethra, and then it goes into the bladder, and then you just basically pee it out. So that's what happens, and it's a closed loop. And I think if you just go again to Dr. Google and ask the question, does transrectal biopsies disseminate prostate cancer? It's going to say yes. If you look into transperineal prostate biopsies, it's going to say no, never been reported. Okay, and it makes sense. Just like there are smaller nerves in the prostate, and so if you do hit a nerve, it's not the end of the world. Now I also do some interesting things. So first of all, we do use here, we do MRR and 3D color Doppler ultrasound guidance. We do put a catheter in during the actual procedure and then take it out. Takes probably no more than 15-20 minutes. Okay, and I can do everything that I want to. I do use twilight anesthesia, and that's the same as you've ever had a colonoscopy. It's this white milky fluid, so you sleep during the procedure. I also do a nerve block, which I think is unique. I'll probably publish it next year, but there's a bunch of nerves which sit over here called the peripatetic plexus and the pudendal nerves, and after completing my procedure, I numb those nerves. So if you do wake up, you may have some discomfort, but it's usually a really low pain scale, and it goes away shortly. So for all those reasons, I really do strongly prefer the transperineal method, but urologists are pretty, it's what they're trained in. They like to do the transrectal, and there aren't many. Like, I'm a uro-oncologist, so I was trained in urology, so it's what gave me a little bit of an advantage to do it that way. So you want to ask your question again, sir?
Well, does advances in imaging delay or replace the need for biopsies?
So he's asking the question, since we have all this wonderful imaging, can we just avoid, biopsying altogether and just go right to a treatment? And yes, imaging has gotten that good. And there are cases where I'll just say it's, 100%, you got cancer, there's no question. However, the insurance companies won't pay. They will not pay for any treatment at all unless you have a diagnosis. You have to have a pathologic diagnosis, and that's the first thing, when a patient comes here, my billing people has to send to that person's insurance to qualify for any kind of treatment at all. Just the way it is. So, I think in the future, hopefully that'll change, but then there are also a few things that we can glean or gain from doing a biopsy, since now we're really into something called genomics, where we look to see if there's a particular mutation associated with a cancer that can drive the treatment to maybe be more targeted, with immunotherapies and this other class of drugs called PARP inhibitors, that kind of thing. Although, right around the corner is coming another way of doing biopsies called liquid biopsies. They've gotten really good. So typically, as the mutations that I just mentioned, that's gained from looking at the pathology tissue of the cancer. But now there are companies that do these so-called liquid biopsies, which aren't quite 100%, but they're close. They're about 80% as good, and also picking up mutations associated with a person's cancer.
How do those work?
Well, they look at, he's asking how that works. Well,
What's the fluid that they're evaluating?
so if you have a cancer, you're going to have circulating cancers. It's just the way it is.
Meaning in the bloodstream?
In the bloodstream.
Okay.
Yeah, and the circulating
So it's a
cells.
blood test?
It's a blood test. Yeah, it's what's called liquid biopsy. It's just a blood test. And again, they've gotten really good at picking things up.
And telling you it's prostate versus something
No,
else?
well, they're getting to be able to do that too, but they're more able to say, yeah, it's probably prostate cancer, and if it is, it's associated with a certain mutation or mutations,
Oh, I see.
which may drive your therapy.
So you might see it on your imaging that there's cancer, and now you can do it.
Right.
Figure
Yeah,
out
but
what
that's a
cancer.
future model, you know what I mean, when we don't need biopsies anymore. But right now, just so you know, and I don't see that changing anytime soon, you have to have a biopsy in order to engage in any kind of treatment. Anyhow, breakfast has arrived, so why don't you run and get some breakfast, and then we'll reconvene for 15 minutes or so.
So sorry for the delay of breakfast. There's a little issue with the delivery.
We'll go somewhere for food. Well, I mean,
Yeah.
So you can do an ultrasound as a diagnostic tool, right?
Absolutely. Definitely. That's what we use here.
I'm kind of tired of having a number 2 on the 3T MRI, and they're telling me, it's prostatitis.
It might be. Do you have many urinary symptoms?
Yeah. I mean, I'm peeing all the time, 3 times a night. Standard stuff. We spoke once on the phone. But you speak to so many people I know.
Yeah.
But maybe it would be worth doing that.
But did you have, you haven't had the 4K score yet. See what that shows.
That should come back. Well, I did have another similar test that you didn't like as much.
Decipher, Polaris, ExoDX.
Yeah, that one. I got a 30 on that, which is.
Yeah. All right. Yeah.
Does an enlarged prostate cause all these sort of problems?
Can.
Really?
You can cause the world of urinary symptoms for sure. Just having an enlarged
Does
prostate.
it show up as a elevated PSA and elevated?
Definitely.
So
Yeah, because the prostate cells make PSA too, normal prostate cells. So you can argue the bigger the gland, the bigger number of cells, more PSA is put out. Then you throw into the mix a little bit of prostate inflammation, and PSA goes wild.
I thought since I drew some blood, I might as well have as many tests as I could think. I tried a PSE for what it's worth. I don't know what that is.
Right.
An ISO PSA, whatever
Right.
that is.
Yeah.
4K.
Of all the ones right now, I think is the most reliable is the 4K. That's been my
I thought
experience.
everyone was moving towards the transfield.
They're not.
Really?
They're not. Just Google, try to find a doctor locally. I mean, what happens is the doctor locally will say, well, I'm doing transperineal. I guess he does it for competition reasons. He knows that I'm doing most of the biopsies. And so to gain the patient, and then he'll do it for a little while, and then they go back to the transrectal. Or I've had patients who walk in and say, I'm getting my transperineal at the very last minute and said, oh, you decided in your case, you're a better candidate for the transrectal. It's terrible.
You seem to have,
Yeah.
you seem to have somewhat of an engineering background. Is the color ultrasound mathematical application of colors relative to density levels, or how is that?
It's flow. It's the directionality. So, for example, we know that our arteries have a certain directional flow, and veins have another directional flow, and that's what we pick up on.
So and that information is not available even on a gray tone?
No,
It's
just not.
at all.
It's just not.
So it's a whole other layer of information. It's not just sort of enhanced readability.
Mhm.
You're not taking a black and white photo and colorizing it.
No. It's
Okay,
a
well-
functional image.
Okay,
So it's absolutely functional.
so you're getting new information.
Definitely.
Great.
Yeah, so that's why I couldn't do without 3D Doppler ultrasound. You're not going to find them around. I mean, we actually have 3, and that's just because we're kind of crazy with 3D, and I had a lot to do with the beginning of it. But if you look around, there's one in Arizona, there's one in Los Angeles, there's one in New York, and there's one in Germany. And we all know who we are because they're really expensive. So urologists can't justify it because their $20,000 ultrasound, is going to reimburse the exact same amount as a 3D color Doppler ultrasound. So how can they justify it? When they cost way high 6 figures, sometimes 7 figures with ancillaries. So
Well,
How does someone end up here? If my urologist works at Intercoast,
if you what?
if my urologist is at Intercoast,
Yeah.
so you guys say, oh, go to the Dattoli's, or how does that work?
Most patients just call. There's a call number. If you go to the website, Dattoli.com, it'll say call us. And, I usually call you sometime, a crazy time of day or night or weekend or something.
All right, so the odds of a doctor referring someone to your urologist.
Well, they might. But, urologists are extremely competitive. They don't want to lose a patient. That's the way it is.
Yeah.
That's the unfortunate side of the reality.
Yeah.
This is
Yeah.
business too.
It is. Medicine's a business. Okay.
That's convincing me I don't want to come here.
Oh, you got that right. I like to watch for me.
Is this yours?
No.
Your color Doppler will look better than that imaging you've done right there.
Yeah. It's pretty amazing, actually.
Really?
Yeah, it's really something. So moving on, so we do 3D color flow Doppler ultrasound. It's a true 3D image, so we can look around. We can go up to the top, up to the bottom. We can scour the whole region, and right, left, up, down, inside out.
You can see the needle where it is.
We can see exactly where our needles are when we do. And so another advantage, since we were talking about staging, is with a color Doppler ultrasound. There we can see violation of the edge. Now let's call it the edge or the margin because it's not a capsule. And we can see that because, again, we're looking at vascular flows. We know that cancers require more vascularity to grow, okay, because they're growing faster. What makes a cancer is uncontrolled cell growth. So they need more blood vessels to keep them going. And so what we can see is that blood flow pattern. So I happen to see a tumor, even if it's bulging, as the radiologist will say, I can see it, but then I can also see a color flow pattern. Oh, that works better. Like this. Then I know it's extraprostatic. Okay, it's really clear. And we have our own screen to watch, to show you. You have your own screen to watch, I should say, to show you that process, and it's very instructive. But it'll let us know if the person's cancer is outside, because as I told you, the way that it's being reported now by urologists is very convenient to them because they want to do, radical prostatectomy, surgical removal. And so they're always going to want to be able to say it's encapsulated. There is no capsule. After a biopsy is done and the diagnosis is secure, typically then, not everyone, but some patients get what's called PSMA PET scan. That is a functional image, which looks specifically for areas not only in the prostate, but outside the prostate, where there may be cancer cells. It is as it sounds. PSMA is prostate-specific membrane antigen. So at first, you do get another injection, and it's not the sugar molecule that every other cancers are given. It's a specific prostate-specific membrane antigen reagent. And it's real, it's been around for about 11 years now. And it will look for other areas that prostate cancer may have spread to. And, the most interesting area that I find, because it could be positive, again, there are these little organs which sit outside the prostate. They're called lymph nodes. And lymph nodes are in our bodies to remove things that are not supposed to be there. And I mean, you may have once had a swollen lymph node in the neck, or know someone who did it. It's tender, accompanying a sore throat, because that's what lymph nodes do. But they also see cancer as foreign. And so as soon as they see it, they grab it, and it goes to the lymph nodes. The PSMA PET scan can show prostate, it can show lymph nodes, and then dissemination, which could be, bones, liver, lungs, things like that. But I have to tell you, it's an inferior test as far as I'm concerned. We do it. Insurance companies now pay for it if you have the diagnosis, but I'm not sold on it because it only shows macroscopic disease. So if you got 10 to the 9 sitting over here in a lymph node, it might pick it up. If you got the same in bones, liver, lungs, it may pick it up. But if it's microscopic, and prostate cancer is a microscopic disease, once again, this PSMA PET scan has become a friend to the urologist, because their whole goal is to remove your prostate surgically. Okay, and they don't want to talk about microscopic disease, even though you can bet the ranch, if you have a high-grade prostate cancer sitting on the edge, it's going to have gone through these lymph nodes microscopically. But the PSMA PET scan will come back and say prostate-only uptake. And the urologists use that too. So they have two of the main tests in prostate oncology, which works to their favor. Number one, the MRI, which says there's a capsule, and two, the PSMA PET scan, which hardly shows. We happen to have a large experience here with imaging, and it's very unfortunate, but between 2008 and early 2019, we were using nanoparticle imaging. And we were working with the University of California, San Francisco, a doctor from Harvard, and this university in the Netherlands called the University of Nijmegen in Radboud. And we had the largest series of its kind. And wow, that it just showed us exactly where prostate cancer was going to, because it showed microscopic disease. And you can go back there and you'll see I published on this along with some big universities. But the fact of the matter, it's a very unfortunate why we don't have it. But in 2014, it was actually the University of Michigan in Ann Arbor. They were the first to do PSMA PET scans. So I guess they combed the United States, and they saw, well, who's doing, advanced imaging in prostate, and they found us. We're doing nanoparticles, and they asked us if we want to be part of their protocol, and of course, and it was free for my patients, and they would have to go to the University of Michigan, Ann Arbor, but we actually had the advantage of having both done, PSMA PET scans and the nanoparticles, and the nanoparticles was so much better. It wasn't even close, and I can't really say they've gotten any better with the PSMA PET scan since their inception in 2014. But we do look at them. I like to look at them all myself because we were kind of on the ground floor of that too, looking at PSMA PET scans. But again, they don't do a good job for microscopic. They do a good job for macroscopic disease. But it's so important because if you find a tumor in your lung or your liver or your bones, it's relevant, in terms of how we approach you and how we might approach you differently. Yes, sir.
So are you still sending patients to University of Michigan for the nanoscopic?
No, so since 2014, and I believe it was 2021, 2022, it started becoming more community friendly, and we do have our favorites around here, but there are several centers in the region that do PSMA PET scans, and they do a good job. They use a pretty similar format as they are at University of Michigan.
So they're using a nano.
type of scanning?
No.
Oh,
So the University of Michigan is just using PSMA. No, the nanoparticles unfortunately went by the wayside in 2019. The only place in the world that's still doing it is in the Netherlands. And the reason, long story, I'll try to make it very quick. So the bottom line being is that I was giving a talk at a national conference, and an investigator from the National Cancer Institute came up to me and he said, "Oh, I love the data we're giving on, on the nanoparticles, and they want to use it." And I said, "Oh, great, I'm glad you are." And he said, "But we're going to use twice the dosing." I said, "Why?" And I showed him my imaging again. It's perfect. And that was it. He said, "Okay," and he left. Well, it was in 2019. We got word that they had almost killed 4 patients with a double dosing of the nanoparticle. The FDA black boxed it. We couldn't get it, and that's the end of the story.
that was a good
So
story.
the only and the only place doing it is the Netherlands, because they're not bound by the FDA, and they got like a 1.5-year waiting list. Just so you know. Wow. Last I heard. Yeah. So anyhow.
Can
Yes,
you
sir.
talk a minute about how the body handles all the radiation from the seeds and from the dark and stuff like that?
So he's asking about
How well is that tolerated?
tolerance of patients being treated. So obviously volume is important. So more volume of areas being treated, you may have more side effects. We really believe in what we do, and it's something called dynamic adaptive radiation therapy. It's as precise as radiation gets, because by being precise, you could limit exposure to surrounding areas. And there's a lot of important surrounding areas that I've discussed: the bladder, the rectum behind the prostate, which sits over here, the urogenital diaphragm, and and then the lymph nodes. Now, lymph nodes are typically strewn between, large bowel and small bowel, and it's moving all over the place. But when we started doing radiation here using the latest format, and I took the team that was using the latest format from Sloan Kettering in New York City to here, and we're still that same team, and we've never stopped refining it. But at first I saw more side effects that I would have anticipated with rectal and bladder irritation with the newer version of radiation, which is still the type of radiation that's being used in 99.9% of centers around the United States and the first world countries, whether it's protons, neutrons, photons, or electrons. And it was only when we started to really refine it and to use image intensity guidance, where we're actually watching or being treated in real time, so that we can avoid those surrounding structures. Now, so that we got down to now, well, you may still have symptoms, but if you do, it's because the prostate is being targeted, and the prostate gets inflamed temporarily, and it shares that inflammation with the rectum and the bladder behind it. And, so you could have a slight degree of frequency is something I hear. You could have some urgency, and you could have some rectal irritation, but that's not so common. But, we've really limited that, and it is a temporary thing. And as time goes on, it just goes away. And there's another side of this, and that is in certain people, we do use hormones. And the hormones can beat you up somewhat, and they can make you fatigued. So in addition to the side effects of radiation, which again, we've really gone out of our way to try to limit that maximally, you can get the side effects of hormones. But in select men, they're a necessary evil. I'm not a hormone bug, and I'll always use the least amount of hormones necessary to accomplish my goals, and which is to cure you. And so, if you really needed 3 years or 5 years, as some places are doing, I would do it. But boy, that beats the heck out of you. I don't like chemotherapy because it drops your immune system. And the interesting thing about radiation is that it actually upregulates your immune system. So you would actually have a stronger immune system as a consequence of getting radiation. Hormones actually do the same. They upregulate the immune system. And the thinking being is that when you give them simultaneously, you could get a spike in your immune system, which could attack cancer cells, not only in the prostate, but maybe for those who have more distant disease that you don't even know about, or you do know about. So the seeding is a very precise type of radiation, and of all the radiations out there, protons, neutrons, photons, electrons, seeding remains the most precise kind of radiation. But I really try to limit, so it appears with seed implants, the side effects are primarily urethral. And the reason that is because while the cancer maybe here, and I'm going to target the heck out of that cancer. But we know that there might be some microscopic cells living around here. So I can't turn off the dose to the entire gland, because if I do, I could be, leaving some cancer cells alone. And so typically, I do make sure that these other areas are getting small doses, but enough to sterilize microscopic disease that we can't see with MRI or 3D Doppler ultrasound. So, but there is a way of doing that. And the way of doing that, there are different styles in the United States. One is called uniform, which means that the seed implants are placed uniformly, equidistant from one another, every single one. And the problem with that is that the best way I can explain it is that if these little seeds, that are now being put throughout your gland, are electric heaters. You just think about this picture. If you happen to be sitting here in the middle where the urethra lives, it's going to get a heck of a dose. It's going to be really hot. Okay? Do we need it to be that hot? Absolutely not. Because we also know that if we were to just put some seeds, most of the seeds around the tumor, and then put some in just some in the periphery, well, they're going to share their dose to the center. Again, if you're sitting if you were sitting in the middle of a room and had electric heaters around you, you're still going to get pretty hot because each one is contributing their dose. Same thing with seeds. And so we don't have to deliver high dose, but enough of a dose that sterilizes cancer around there, that still can give a urethritis, meaning irritation of the bladder system, the voiding system. And that's, we usually can hear about frequency, urgency, a stream being weak. Again, it's temporary and then it goes away. So that's pretty much it. Does that answer your question, sir? Yes. Okay, well, I believe our session is complete. Okay, so thank you all for coming. And we'll let you know when the next one is, next prostate cafe.
Thank you, Doctor.
Yeah, of course. Yeah.
I knew.